Good morning and welcome to Global Healthcast, our weekly information on vaccines, vaccination, and on infectious diseases. I am Joe Schmitt, and with me today, as always, is Dr. Melvin Sanicas. Good morning, Melvin.
Good morning, Professor Schmitt, and good morning, good afternoon, or good evening to those who are watching.
The topics today, as always, are COVID-19 update presented by Melvin. We then have good information, good news about an additional RSV vaccine data that have been published in the New England Journal of Medicine. And this vaccine has been licensed yesterday. We'll inform you about that. I will talk about COVID-19 past and future vaccine platforms. Melvin will cover HPV vaccine. One dose may be sufficient. And then we continue with our series on most infectious diseases. And today, Melvin will cover Lassa fever. Melvin, what's the update on COVID on the world?
Yes, so for those of you who have been watching our Global Healthcast, you already know that we start with this quick global COVID update. And this is something that we get from the WHO COVID situation report. You can Google that and you can get more information for yourself. And this is not real time. This is a week late. And here, what you are seeing is that the cases and the deaths are going down. So over the past few weeks, there have been 2.8 million new cases and almost 18,000 deaths reported globally. And this is, of course, again, a reduction as compared to the previous week. But contrary to the overall trend, significant increases in reported cases and deaths were seen in some regions of the WHO. So in the Southeast Asia region, for example, in India and Nepal, they reported more increases. Indonesia also reported an increase in cases over the past 4 weeks. And in the Eastern Mediterranean region, there have been increases in Qatar and Saudi Arabia.
So overall, good news, but you have to look locally to be sure that there are no niches where you have a different effect.
Yeah, that's the message.
Very good. And this is the map on morbidity.
This is the map on the number of cases. So this is the new 28-day cases. So this is basically looking at the past 28 days. And the top 5 countries are the US, the Republic of Korea, which is South Korea, the Russian Federation, France, and Brazil. So these are the top 5, but there are other countries, if you see in the map, that are reporting increases as well.
Mm-hmm. How does this relate to mortality?
So if you look at the mortality now, this is the map, you will notice that some of the countries in the top 5 are also still part of the top 5. But there are countries that are now there that were not part of the top 5. So for example, Germany and Iran, right? So these are probably countries with more elderly, or I don't know what is happening there, but basically these are countries that are not in the top 5 or not even top 10 in terms of cases, but in terms of deaths, these are they were included.
Interesting. Actually, the German NITEC, the STIKO, just recommended to basically stop vaccinating if you have had your 3 doses in the past, and to only continue vaccinating if you are of older age or if you have an underlying disease. And I don't cover the detailed information, but we talked about that in our previous podcast, that COVID is now becoming usually a mild disease, except for some risk groups. And the risk groups you can see in our Global Healthcast 33 and 34, I guess. Mm-hmm. Melvin, what else is new on COVID?
So if you go to the next slide.
Here we go.
Yeah. So this is showing us the variants, right? This is table 2 from the WHO report as well. It shows the number of countries reporting the variant of interests, or the VOIs, and the VUMs, or the variant of variant under monitoring. So there are three categories of variants. We have the variants of concern on top, which basically, as the name suggests, right, it's something that we are concerned about. And then we have variant of interest below that. So this is something we're interested in. So it's below variant of concern. And then under that, we have the variants under monitoring. So these are the ones that potentially may be of interest, but at the moment they're just being monitored. So I think the names are pretty clear, right? And this week we see that there are a lot of XBB 1.16 and other XBB subvariants. And basically this is just showing us how they have progressed so far and the number of countries that they're in. So if you look at the chart, you see that these XBB 1.16, which is now a variant of interest. This is the subvariant that has been causing the increase in India and Nepal, and it's now in at least 31 countries.
Interesting. So this will continue to be, people probably will continue to monitor these variants, even if the pandemic may be declared to end May or June or whenever we expect this, right?
Yes, so I mean, we have been expecting that to be announced by the WHO in May or June, unless we have another curveball, like another new variant that really causes a lot of problems. So we will see.
Would you expect that one of the current lineages reverts to become a more virulent strain and kill again some percent of the population?
Well, not maybe killing, because even if they change, in its essence, it's still a SARS-CoV-2. And for some reason, our immune system, it's also quite interesting, right? Because even though these subvariants have changed as compared to the Wuhan strain or what we have in the vaccine or what is actually in the bivalent boosters, we still see some protection. And I think it will really not be like in 2020, where all of us, right, all over the world, we were really naive and we have not seen the virus.
I think we have had coronavirus threats now every 10 years for the last 30 years. We are in the third threat, right? That was the biggest one and the most challenging one. So I would expect that a totally new coronavirus may cause the next coronavirus pandemic in only 8 years, statistically.
Around 2030.
Yeah, 2030. Think of us and remember Global Healthcast 35. Melvin, I have another RSV vaccine for older subjects that was published in the New England Journal of Medicine to be efficacious. And that vaccine is called RSVPreF older adult OA, Efficacy, older adult. And this is produced by GSK. So it is again a pre-fusion protein. The same as for, or similar as that from the Pfizer vaccine that we talked about last time. I still have to find out what the 3 stands for, but OA is probably older adults. And this is the case because it is adjuvanted with an adjuvant ASO1E. And as this is adjuvanted, you cannot use it in pregnant women. This is the difference. The Pfizer vaccine is the same for pregnant women. And that is a vaccine I had shown to you, or the efficacy data I had shown to you before. And it is also licensed now for older. It has been shown to be efficacious in older adults, but it has not been licensed yet. So basically, this was a placebo-controlled phase 3 trial, 1-to-1 assignment versus placebo, adults as of 60 years of age. The vaccine has an adjuvant. It is this F protein, the pre-F protein again. It is 120 micrograms of one of the subtypes only, whereas the Pfizer vaccine has both A and B subtypes, but the dosage then is the same, right? It's 120 micrograms. And with the adjuvant, adjuvants give you higher, longer lasting and broader protection. So with the adjuvant, GSK had hoped that you would cover both subtypes. And let's look at the results. 25,000 subjects were included, and the vaccine efficacy against lower respiratory tract infection was 82%. The efficacy against severe lower respiratory tract infection was 94%. The severity assessment was done by the investigator, and that is different from the Pfizer trial, where there was predefined criteria, 2 or 3 symptoms that made the assessment by if this disease was severe or not. Then there is RSV, acute respiratory tract infection. So this is any RSV infection with any symptoms, 71%. And then you have here the comparison between the two types, and you see it is a little bit higher against type A versus type B, but I guess the differences are not statistically significant. The reactogenicity was acceptable. It was more than placebo. There is no serious adverse event concern or potentially immune-mediated disease concern in any of the groups. And now what I did is what you should never do, and I will take it out of the show notes, but I'll do it anyway. This is now the data from the Pfizer trial, just as a comparison on the same slide. RSV, lower respiratory tract infection with 2 symptoms. So we have to go lower respiratory tract infection. This is 82, this is 66. So there is a difference, but we don't know how the definitions compare. This is with 2 symptoms. This is lower respiratory tract infection. It may be 1 symptom, but we don't know, right? You cannot compare. For 3 symptoms, this relates probably to severe, and that is 85 and 94. And if you go RSV, RE, which means any infection, it's 62, and here it is 71. It looks on paper that the GSK vaccine is roughly 10% more efficacious, and that may be due to the adjuvant. It would be biologically plausible, but we have to be very, very careful because this was not a head-to-head study. And it may well be that if you use a head-to-head study, these differences disappear. We don't know, basically, right? And this is the Kaplan-Meier plots for the results. What you see here very nicely is at some point, there was no more RSV, which may be due to the COVID pandemic, right? Everybody was wearing masks, and then you don't see any cases anymore. So this is RSV-related lower respiratory tract disease, and this is RSV-related RE, so any symptomatic RSV infection. Very nice data, very nice Kaplan-Meier plot, and you nicely see that the vaccinated group is better off than the unvaccinated group. And again, this is the Pfizer data from last week. I leave these in the show notes for yourself to compare. And yesterday, the new vaccine was licensed. The brand name will be RSV. So you can find this on the internet site of the European Medicines Agency. I encourage you to go there and read all the details about this new vaccine. Melvin, any questions, any remarks?
So, Professor, just a question. So now that it has been approved by the European Union, the EMA, does this mean that in the next few months it's going to be available in the whole of Europe?
I did not ask anyone from GSK if it would be available, but usually the product for the phase 3 trial comes from the factory where the vaccine is produced. So provided there is, so provided there is production capacity, and I would assume the company has that, that would be available. And the question is if it would be recommended by end of the year, right? Look, I worry about RSV. I'm 60 plus, as you can see from your video here. I'm 60 plus, and I would be happy to be vaccinated against RSV this before the winter, right? So I think about that, and I would bet they have production capacity around, and it will be available. The big question is if recommending bodies are ready to recommend this. They are slow in Europe, and again, PCV7 took 7 years for political reasons, and I'm not sure how politics and NITEX arrange themselves if they recommend it or not. So I have no idea where this will go, but let's see. Okay. All right. My next topic is now COVID vaccines. And I found this here on a website of the University of Oxford. What you see here is the Pfizer-BioNTech mRNA vaccine sold 153 billion doses globally. Moderna had a quarter of this. Oxford Seneca, 10%, 15 billion. The Beijing, the Sinopharm vaccine, 5 billion. Johnson & Johnson, 3. Sputnik, the Russian vaccine, 2 billion. And what you see here is mRNA, adenovector. The Sinopharm, they had a comparatively low vaccine efficacy. This was whole virus, WV, whole virus. Adenovector, whole virus, subunit adjuvanted, Novavax, 110 million. CanSino, adenovirus. Valneva here in Europe had whole virus. Sanofi GSK, subunit adjuvanted. And here's one, South Korea and GSK, subunit nanoparticle ASO3 adjuvanted. Very interesting. So this is the past. And the information is that more than 20 million lives have been saved in 1 year alone by vaccination, which is quite a number, right? This is twice the size of New York City. I think this is just a relevant number of lives saved in 1 year alone. And the question is then, what will be the future? But before we go to the future, Melvin, any remarks on this side?
Now that you mentioned that it's like twice the size of New York, it makes, it made me think that it's like 3 times the size of Switzerland.
yeah, 3 times or 4 times the size of Singapore, right?
Yeah.
Something, yeah. Good comparison, yeah. All right, this is the future, and this is from the WHO website. What you see here, candidate vaccines, protein subunit is what most people go for, 32%. Then viral vector, non-replicating, 14%. DNA, 9%. Inactivated virus, 12%. RNA, 24%. Then we have viral vector replicating. That is 2% here, right? You know about the concerns with these replicating viruses. Then we have virus-like particles. Then we have viral vector plus antigen presenting cell, a whole new idea. I don't know the details about, but sounds very interesting. We have live attenuated virus. We have viral vector non-replicating plus antigen presenting cell. So this, I guess, is the same approach with the antigen presenting cell. And then we have bacterial antigen spore expression vector. I don't know the details of that, but sounds very interesting. 183 candidates for COVID vaccines out there, and none of them will be a big commercial success because the winner is here, right? It's the Coca-Cola and Pepsi story. If you're number one, you will be always the number one. But why do all these companies come up with different vaccines against COVID? And the explanation is quite simple. This is platforms. And everybody will use COVID vaccines in the future, maybe for risk subjects only, but you will be able to run studies on a global scale with these new platforms. That is why everybody is doing this. And once you see that it's working and there is no concern, then you can change the antigen and you can change the target, and then you have a vaccine against zoster or influenza, all influenza viruses, or whatever you come up with, right? So I guess this is the idea about it. You have the platform, this is platform studies, and they use COVID as a target antigen at this point, and they will change that again later. Melvin, any idea, any views on this one?
Yeah, and just to add to what you said, Professor, I think all these platforms are going to be useful because in the future, who knows, those other diseases we discussed, like the Nipah virus, Lassa fever, Crimean Congo hemorrhagic fever, they might need vaccines as well. And all these platforms are going to be helpful in creating those vaccines that are not yet available at the moment.
Yeah. And the best platform for a given target may change with the target. For some viruses, look, the yellow fever vaccine is a great vaccine that probably gives you lifelong protection. Or hepatitis A vaccine, that was just a chance finding. This was a great vaccine strain, and you need very little boosters, if any, if you had your primary series, to be protected for life. So it depending on the target, a
The
different
pathogen,
platform
yeah.
may be ideal for one given disease in the future.
Exactly.
Anyway, Melvin, you will cover now HPV.
Yes, so this is actually a study from Kenya, from the KEMRI, which is the Kenya Medical Research Institute, and it is a state corporation. It has been established a long time ago, but it's really one of the centers of excellence in health research in Africa and globally. And this is a study that basically showed that one dose of the HPV vaccine seemed to be efficacious over 3 years. And for me, this is good news because this HPV vaccine actually started initially many years ago as a 3-dose vaccine, right? So Gardasil from MSD Merck, and then we had Cervarix from GSK. Initially, they were 3 doses, and then it became 2 doses. So apparently, 2 doses are enough to protect young girls. And then now this study is showing that maybe one is also good enough. And we are talking here about access and affordability, and basically for those who only got 1 dose, maybe it's good enough for them as well. But of course, this is not changing recommendations at the moment. This is just showing us that maybe a single dose could be enough as well.
Very interesting. I guess this is also, they started age 15 years, right?
Yeah.
I think the initial license goes down to 9 years.
Mhm.
So there may be a different story with here why you see protection against infection with 1 dose only, and 3 years is a little bit short, right? Your
Yes, it is
sexually
short.
active life is probably some decades and not 3 years, right? So I'm very interested in this because I have two twin daughters. So I wonder what to do with them, right? Should I give whatever vaccine 3 times, or should I give it once only? So I have to think about it, right? Anyway.
Yep.
Now we come to our next topic. Melvin, this is all yours.
Yes, so we started with the Nipah virus in Global Healthcast 33, and then we talked last week about the Crimean Congo hemorrhagic fever in Global Healthcast 34. And basically now we are talking about the third one, which is the Lassa fever. Next slide, please. Next one. So Lassa fever is an acute viral hemorrhagic illness caused by the Lassa virus. It's a member of the arenavirus, and humans usually become infected with Lassa virus through exposure to food, household items contaminated with urine or feces of infected mastomys rats. The disease is endemic in the rodent population in parts of West Africa. And personally, I've only heard about this when I spoke to my friends from West Africa. Apparently, this is endemic in countries like Benin, Ghana, Guinea, Liberia, Mali, Sierra Leone, Togo, and Nigeria. But it probably exists as well in other Western African countries, and we have not just heard it being reported. So person-to-person infections and laboratory transmission can also occur, especially in healthcare or research settings, in the lab, for example, in the absence of adequate infection prevention and control measures.
Interesting.
So, yeah.
And it is the virus reservoir is rats.
Yes, that's right.
And why is it not present in rats in Europe?
We don't know the answer to that. Maybe it could be if it's brought here.
Yeah, interesting.
So this is showing us the transmission, basically, of the Lassa virus. It's, as I've mentioned, it's found primarily in the multimammate mice, or the Mastomys natalensis. It's native to West Africa. So maybe it's because these rats have receptors to these virus. I don't know. I'm just speculating here. But the virus is transmitted to humans through contact with the mice or their feces or their urine. And the overall case fatality of Lassa fever is around 1 to 2% actually. So it's lower than the previous two viruses we discussed. So it's much lower than the Nipah virus or the Crimean Congo hemorrhagic fever. But high-risk individuals are pregnant women, children, and for those who have mild disease, they will have symptoms like vomiting, diarrhea, chest pain, headaches, which are very non-specific. So this is showing us the evolution of the disease from symptom onset to other outcomes. So initially, in the first few days, you will have the fever, extreme fatigue, general weakness. And then by the second week, you will have face swelling, low blood pressure, nose bleeding. And then as the infection progresses, then you will have more severe outcomes. The worst outcomes will be there. And as I've mentioned in the first two slides of Lassa fever, the population that's really affected most by this virus are the pregnant women and children. It's particularly severe in pregnant women and their fetuses, and it increases really maternal mortality in the third trimester. And in infants, it can present as a swollen baby syndrome and is associated with a high case fatality rate. So again, the reason why we're discussing these viruses is because there are no treatments and there are no vaccines. And that's the reason why, so Lassa fever, Crimean Congo hemorrhagic fever, and Nipah virus, that's the reason why we are discussing them, because they are part of the WHO blueprint for research.
Yeah. It is very interesting that pregnant women are affected, which we know that fever is maybe detrimental during pregnancy. But I guess here it is more than fever. It is also the virus that is present and probably circulating in the blood, as I would assume, right?
Yeah, and all these weird cytokine and all these different substances that are in the body because of the infection.
Yeah. Very good. Thank you very much, Melvin, for these insights into a disease that we don't know here in the middle of Europe. So very interesting. Thank you very much. And we will keep you updated on the other diseases on the list next time. With that, the summary is COVID-19 update. Numbers are going down, cases as well as mortality, with some exceptions. So get your local updates. I then presented the RSVPreF OA adjuvanted pre-F RSV vaccine, which was published to be efficacious in older adults and which is now licensed by EMA. First RSV license, to the best of my knowledge, in the world. COVID-19, past and future of vaccine platforms. I presented the winners of the vaccines we have been using over the last years, as well as new platforms that are out there and that probably will be used for future vaccine targets. Melvin presented HPV vaccine that one dose may be sufficient, a study from Kenya. And then you heard all about Lassa fever in the last minutes from Melvin. And Melvin, you have one last slide. Maybe you can explain to us.
Yeah, I think we don't need to explain it, but basically it's easy, right? When you are hungry, your stomach alerts you because it's empty. But for people whose brains are empty, it alerts other people and it doesn't alert you.
Very nice. Very good. Thank you very much for this insights into your own research, Melvin. Thank you very much. And I thank everybody for joining us today. I am Joe Schmitt, and with me was Melvin Sanicas. Goodbye, Melvin.
Thank you, everyone, and stay safe.